Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
I'm Dr. Ira Nash. Welcome to Well Said. Today, we'll be discussing shingles and the shingles vaccine. Shingles is a painful skin rash caused by the same virus as chickenpox. But unlike chickenpox, it typically affects adults over the age of 50. Since 2017, a vaccine for shingles has been widely available. But who should get it and what does it protect against? To answer these and other questions, I've invited my colleague, Dr. Frank Cacace. Dr. Cacace is the Associate Chief for Education in the Division of General Internal Medicine for Northwell Health and an Associate Professor of Medicine at the Zucker School of Medicine. And I'm delighted that he's joined us today. Frank, welcome to Well Said.
Thank you, Ira. Thanks for having me.
So we're just past the 2-year mark of this incredible, unprecedented pandemic. So before we start talking about shingles, I just want to ask how you've been making out and how you're feeling.
Thanks for asking. Yeah, it's been a wild ride for primary care docs. That's what I am. I'm a general internist for the family practitioners and the pediatricians and the geriatricians. We've been taken through the gamut of, a number of challenges trying to persevere through it. I will say that I wound up with my first leave of absence over 28 years through it and got a breather in for about 8 to 9 weeks and came back. And that was in September to November of last year. For me, being in the exam room and talking about the virus and taking precautions and what the numbers mean in our communities and having vaccine discussions, it's really been an important part of being a primary care doc. And some of that's been so gratifying, and just a bit of it's been challenging, the conversations in the exam room.
I'm sure. Well, thank you for that work. And we're going to be talking about a different vaccine a little bit later. But let's start with the condition itself. So I said a little bit about shingles in my intro, but why don't you give us a better picture, a more complete picture of what shingles is from a clinical perspective?
I'm in this conversation a lot with patients of all ages. Even though this vaccine for shingles is approved for 50 plus, we talk to some young people about shingles too. Occasionally they get an outbreak. So what shingles is a rash that appears on the skin of a nerve map, particular part of skin that is served by one nerve root, and that rash is often a red, hyperpigmented rash, increased pigment compared to the surrounding skin, and then it's got blisters on it. Those blisters are there for a few days and then open up and then crust over, much like what original chickenpox does. It's a blistered rash that crusts over. So the difference in terms of what the patient sees and what we see is that the rash only comes out left or right side of your body, only on one territory of a nerve. And that's because, interestingly, our original chickenpox when we're younger, being a herpes virus and human immune systems not being perfect for eliminating herpes virus, 100% of the particles, we hold on to some of them, and they live in us. They go to sleep. They don't quite pay us rent, but they pick a single nerve root in the spine or a single nerve root up in your head and scalp and some of the cranial functions. We've got nerve roots up there that take care of those functions. So randomly, that virus picks a nerve root to go to sleep in, and then at a time it's allowed to awaken, at a time of reactivation.
Before we get to that, because I think there's a really interesting story to tell about how the virus reactivates. But let's talk a little bit more about the clinical syndrome itself. So this rash can be quite painful, right?
Yeah, a lot of times it starts with just a little itch or numbness and tingling in the area where the rash is about to express itself. But then when you've got the red rash and the blisters over it, that rash can really get pretty uncomfortable. Patients will use a lot of different words. It's ultimately nerve pain because virus did awaken out of a nerve root, say, in your spine, traveled the nerve itself, came out to the skin along that nerve's territory. So this will be described as nerve pain. People use the words like burning, like tingling, like a lancinating pain. That's a fancy word for saying it's a pulsing, sort of stabbing pain, quick twinges of pain along the rash area. And then there are people who have zero pain. I'll tell you, younger folks who get rash don't get a lot of pain.
That's interesting.
But the older you get, the more pain you have.
I guess depending on where this is, this can either be kind of just a nuisance or something that can be really quite problematic, right? Yeah,
I mean, if it's on your chest and back in the shape of the letter C, half your trunk, midline to midline, chest, side, and back, you know, putting a shirt on is no fun. Having the T-shirt rub against it. It's like this poor 80, 85-year-old patient, like, doesn't know what hit them, you know, and they'd rather have their skin open to the air if they can. It could be on half our forehead. So being on half our forehead or in our scalp, you know, we'll start noticing that combing our hair is no fun. Just the tug on the hair, on the surrounding skin, being involved with virus can be tender. An ear can get tender, depending on the nerve territory in the face where the shingles shows itself. And, you know, this idea that it can be in any random nerve root, I want everybody to think of it like being a herpes virus. Herpes simplex, HSV1, i.e. cold sores. We love to call them cold sores on the lip or just inside the nose, two most common places for that virus to reactivate, also a herpes virus. The reason it shows up in the same place is that almost all of us with first infection get it only in one single nerve root and territory. Not so with chickenpox. Chickenpox can be along any spinal nerve root. Therefore, it can hit us in a leg. It can hit us in the trunk. It can hit us upper chest, lower, belly, and then somewhere along our face.
Right. And if it happens to be in the face, if you get it in your eye, that can be bad news.
Yeah, so we go out of our way to make sure that we've understood what the complications could be based on the territory virus reactivates on the face, and we teach it. We make sure our students and residents know this. But bottom line is, if one forehead has got blisters on it with a red base, and that rash tends to involve the tip of the nose in addition, that particular pattern almost always means there's virus on the surface of the eye. And so those patients need to see the ophthalmologist very early in the course so that they can have that confirmed. That treatment's different. We're worried about the surface of the eye, the cornea, having viral inflammation on it. So yes, half the forehead with tip of the nose on that side, we know that person needs an eye exam.
Okay, so let's get back to this kind of funny relationship between chickenpox and shingles. So we're old enough that when we were kids, everybody got chickenpox. Now there's a vaccine to prevent chickenpox in children. So kids
Correct.
Don't get chickenpox the way they used to. Do I have that right?
That is correct, which is a wild thing because we think about our patients differently because of that.
And what's the sort of dividing line when you start thinking about people, oh, this person must have had chickenpox because they are X years old, and this person probably didn't ever have chickenpox because they're a different age?
I believe that chickenpox vaccine as part of a primary series for kids got started about 15 to 20 years ago. So if folks were born before that, So that would put us, before the year 2000 approximately. I, as an adult doc, will consider that person potentially somebody who had chickenpox when they were very young. The pediatricians' vaccine pages and pages that document childhood diseases really help us at the transition. We'll take new patients on as adult docs at age 18, 19. So we'll really go out of our way to get those vaccine pages and also the pages that document whether or not they had chickenpox as a kid. But prior to that point, we pretty much presume everybody got exposed to chickenpox, even if they don't remember having a case. Often the person doesn't remember having a case because they were exposed and it was a weak exposure. They made a very nice antibody and then never got a rash.
I see.
So we pretty much presume everybody to have been exposed to chickenpox.
So you're talking about a huge population of people who were exposed or actually had a clinical case of chickenpox, but not everybody goes on to get shingles later in life. So explain that.
Yeah, so by the time we're 85, 90 years old, 1 out of 3 of us reactivate chickenpox, again, being a herpes virus, so, we're vulnerable to reactivating it. 1 out of 3 of us will reactivate by the time we're 85 and 90. There's 1 million cases, approximately 1 million new cases of that reactivation that occur in the country per year. And so reactivation, we think of it that the immune system was distracted a bit. It was distracted for a week or two prior. And so the story will go something like this. Either that immune system was distracted by fighting off another, significant bug, landed us in bed, really not feeling well with a pneumonia, with a deep bronchitis, with a viral syndrome that gave us a lot of malaise. So that's one scenario. Another scenario that could have our immune system, quote unquote, distracted is that I'm a patient that takes medicines that alter my immune system for things like rheumatoid arthritis and lupus, or I'm a patient whose immune system is just different anyway, just as part of my medical history. And then finally, I see it all the time, patients who are in the middle of something either very stressful or very happy. They're moving into a new home and they're just loving the thought. And, they're organizing, and they just don't sleep well 3-4 nights in a row. So their immune system gets distracted by the stress of life's experience. And next thing you know, there's a couple of painful blisters on my forehead, Doc. I don't understand what this is. And, we'll get them on the video in the day and age of televideo, and it'll be pretty clear. We bring patients in and just get recognition going for the rash in that setting. So those were good examples, I think, of who reactivates and why. It's basically letting a sleeping virus wake up.
That's interesting. And I suspect that mingled in there are any number of people for whom it's not really clear why they developed this, right? They had chickenpox as kids, and now they're in their mid-60s, and all of a sudden they wake up one day with a rash.
Last case my residents and I saw, the last person with a case was only last week. She was 42 and couldn't figure it out. Nothing crazy going on in my life leading up to this, and I wasn't sick really. So, yeah, I'll admit sometimes some things don't fit into our nice narratives, and they're not meant to be understood. And for that patient who's a little frustrated, I put a hugging motion up to the air, and I say, "This is me hugging uncertainty. Let's hug it together."
Okay.
We hug together.
I'm going to use that line, Frank. I like that. If somebody does develop this for one of the reasons that we've just reviewed, and they are uncomfortable or they're concerned about this getting worse, what do you have to offer them to make this go away faster or shorten the course or make it less uncomfortable.
Right. So I think you're knocking on the door of, when the prescription pad comes out early in a case, what can we do to make it a better experience for the patient? And then I gather you might be headed in the direction, because the other question to be asking here is, what can we do prescription-wise to perhaps have an impact on the dreaded complication of shingles, which I guess I can get into it with part of this answer. So we use direct antiviral that has activity against the herpes family. And I think the one that really is the most popular these days is valacyclovir, V-A-L-A, valacyclovir, in a good dose 3 times a day. And it's used for 7 days to kill virus quicker in those blisters and along the skin and along the route of the nerve. So we get viral load down as quick as we can, and that's helpful. I would say anecdotally, meaning I'm not quoting any big study here, but I would say patients respond to that along the lines of, say, 60 to 80%, where their number of days of suffering, if the pain is a significant thing with their rash, is cut back, and the number of days to get to the crusting phase, where they're not shedding any virus, is cut back. And then finally, the big deal, and that is that because that virus came out of nerve root, whether it be up in your face or along your spine, it really, sort of beat up the road along the nerve to get to the skin. So that nerve's pretty inflamed. So neuralgia is our word, algia, pain of, nor the nerve. Post-herpetic means after the rash. And one of the big rationales for vaccine is to try to cut down on this as well. 60 and above get stronger and stronger cases of the neuralgia, which can last anywhere from 6 to 9 months. It's not nice to have that part of your, chest and back still that sensitive to touch and feeling that burning feeling, for half a year afterward. It's tough.
So let me just review what you said, because I want to make sure we keep this clear. So that the treatment is helpful in shortening the duration of the acute illness, and also, and I guess this is a question, does it also lessen the risk of this going on to that more protracted post-herpetic neuralgia, the persistent neuritic pain that comes after shingles or can come after shingles?
Yeah, I think that the really detailed evidence is not quite as strong for the antiviral as it is for vaccine.
The idea of preventing shingles is really about making sure that people don't get shingles, because it's not that the shingles itself is so terrible, it's not great, but what we're really trying to prevent is this complication of shingles that occurs in a certain percentage of people who get it. Is that fair to say?
Correct. That is correct. And the older I get, from our groups that we're considering for vaccine, age 50 to 60, 60 to 70, 70 to 80, 80 plus, the incidence of that neuralgia complication slowly rises with each decade.
Yeah, so the risk of getting shingles goes higher, and if you get shingles, the risk of getting this painful post-shingles syndrome also gets higher.
Indeed.
Yeah, okay. So that's a good thing to prevent. So talk to us about how we prevent that.
So what the idea here of a vaccine would be is to say that our own immune system, having seen chickenpox in our younger days, has a memory for it. And from memory, it makes a day-to-day antibody level. The more years we get away from that original case, the more that antibody level will tend to wane, just naturally. So year to year, it'll still be picked up, but there'll be less level showing up in a routine, blood draw, until finally when a year comes when really it won't show up at all. Now, we don't routinely check that antibody level to make the decision to give vaccine, because we can't hurt anybody with vaccine it is ultimately a booster effect. We are waking them up. We are waking up the arms of the immune system that have seen chickenpox younger, and we are saying, here is the surface protein, and glycoprotein is a mix of a sugar and a protein from the surface of this virus. Here, immune system, recognize this again. When your immune system does that, it explodes. It makes the product again, and it puts it there in a higher level. And to have that product sitting in place is what gives us our great chances that our case, if we are destined to get a case, that it will be a milder case, and that our chances of having neuralgia are so much less. This vaccine has an effectiveness to it that's been studied over a 4-year period, and I can get into that and into how long we think the antibodies last. And also, Ira, some of your listeners may remember there was a first shingles shot. There have been 2, and the one we have now is called Shingrix. It's a 2-shot series. And then years back, maybe about 10 plus years ago, there was Zostavax, Zostavax, and that was a single vaccine. There are differences between the two. And something I find myself reviewing with patients a lot is, hey, doc, if I got a Zostavax, and I see it in their chart, it's been documented beautifully, it's there, do I really need that next shot? So I'm happy to cover all of that. But the official indication right now is age 50 plus should start considering the current vaccine, which is a 2-shot series called Shingrix. And the second shot comes anytime between 6 and 8 weeks after or later. That's when you get that second shot of 2.
So let me ask you a couple of questions about that. So
Sure.
Presumably Shingrix displaced the earlier vaccine because it's more effective or less problematic in some way?
1, more effective, and 2, the old vaccine was a different technology. It was a single shot, and it was an attenuated live vaccine. It meant that there were weakened live viral particles in that vaccine. There's a number of vaccines out in our world where that's true. This one is no live material, only the mixed sugar protein surface component that's presented to our immune system. So no live material, which is important for households. Pregnant women should not get a live vaccine. Somebody receiving a live vaccine returning home and there's somebody pregnant at home, not a good idea, because some of that virus could be shed after vaccine. And if somebody's immunocompromised at home, not a great idea to use the old live vaccine.
So it's safer.
So the new one is really, that concern is out the window. Family members, if I'm immunocompromised myself because I have a new kidney and I'm on meds to avoid rejection, all of this is done being a worry with the new 2-shot series that is not attenuated live.
This is a different vaccine from the chickenpox vaccine the kids get. Is that correct?
That is correct. So that one's called Varavax. So much for not using brand names. And that is also attenuated live that the kids get. And Zostavax was as well. Shingrix is a beautiful, non-attenuanew live option.
You mentioned something about shedding virus after getting the older vaccine or
Yes.
I guess the new contemporary chickenpox vaccine, which leads to a question that I should have asked you before, which is zoster contagious? I mean, we know that chickenpox is wildly contagious, one of the most contagious diseases we know. But what about zoster? I mean, if somebody has shingles, or I guess zoster is the other name for it, but are they a risk to people around them?
The risk is not nearly as much as with varicella chickenpox, because chickenpox can cover us head to toe and loads of viral particles in each one of, so many blisters. boy, I remember my case. I wound up having blisters in places I didn't even know existed on my body. But that's a little too. Was that TMI? That's too much information.
A little bit much, Frank. Yeah, we could have done without that, but it's okay.
Yes. So shingles being such a miniature version of that, i.e., it's one territory, left or right body. I will say that technically, when those are still blisters, there's virus in those blisters. There is. So I think that there might be some considerations here. If it's a part of the body that could be covered easily, with T-shirt and shirt, or your trousers, then you're in good shape. I think that when it's on the neck or the face, maybe the hands, you might want to be careful. And here's why: if there's a new baby at home who hasn't started vaccine series yet, that I'd want that person, I'd want grandma or grandpa not to be around until the blisters clearly crusted over. If there was somebody in the home who was on long time prednisone for a liver transplant, I would want the person with shingles to not be around, particularly if it's a part of the body that cannot be covered. If there was a pregnant woman at home, same thing. So you get my drift. I think there are some vulnerable people who could take on that virus from somebody with shingles and get pretty sick. So it's a matter of strategizing with your doc as to who you live with.
So that's very helpful. And I want to return to the vaccination part of this story, because it's really fascinating, right? We have a vaccine to prevent the initial infection in kids. So presumably sometime, decades from now, we won't be getting shingles either, because nobody will have had chickenpox.
I think the only folks who will be vulnerable to shingles at that point will be folks who didn't take, for one reason or another, did not take vaccine when they were kids.
Okay. So we have an effective way to prevent the initial infection of chickenpox. We have a way to effectively prevent the recurrence of a different kind of infection with the same virus that we call shingles or zoster. I can't help but think about the current controversy, which really ought not to be a controversy, about COVID vaccination. And even though we have these other success stories staring us in the face, what's your take on that?
Oh boy, how much more time do you have, Ira? So I guess I want to frame some thoughts with reminding all of you that this vaccine has a pretty good 4-year effectiveness studies, the Shingrix. It's about 96 to 97% effective from age 50 to 69, and over the age of 70, it's 91% effective. People think that based on modeling studies, those antibodies would last for 10 to 12 years. Similarly, the neuralgia as a complication, the Shingrix is effective in the area of 85 to 90%, depending on how old you are.
Before you go on, so I just want to make sure we get the current recommendations out there. So who should be getting this vaccine, Shingrix vaccine?
Anybody over 50, it is recommended to take a 2-shot Shingrix series. I meet plenty of patients who are 62 and 65 and 70 who haven't had vaccine yet, and that's well and good. Anybody over 50. And there was a recent recommendation that those who are immunocompromised between the ages of 18 and 50 could, in fact, consider Shingrix as a smart thing to do. So I want to remind everybody that the original vaccine, Zostavax, by 6 years out, Zostavax, that single live vaccine we were talking about, is only 35% holding, 35% effective. So we didn't know the answer to this, but I think we do now. I think that if your patient has had Zostavax 5 years ago, you should give them Shingrix now. That's pretty much what I'm starting to do. And then coming back to your question, wow, yes. The COVID deliberation. Let me use that word. I've been on the front line that way. When the mRNA vaccine came out, it's a different technology that was already in place for SARS-1, and those scientists were just ready. They were on the ready for an event like this. When that vaccine came out, there were loads and loads of good questions, really good questions, and from so many different angles. The variability of the questions. I really enjoyed those conversations. You know, you hear people out, you actively listen, and you make sure you understand their questions. And sometimes it took a few visits to get people to get confident to take that vaccine. But, you know, we've achieved probably about 60 to 70% vaccine rate for the COVID vaccine. As the weeks and months wore on and the variant outbreaks wore on, boy, it got different in the room. It involved a lot of, you know, sad mixing of politics and public health. And, you know, you saw the occasional patient who it was a bit more important to stick to their guns in terms of their own Facebook pages and their own, you know, cable news, and only hear their own echo chamber on how they felt about this vaccine. And, you know, there was a lot of dialogues that just were not very helpful out in the world. And I'm going to tell you, as an internist, that really took something out of me with the months and the years of the folks who weren't going to go ahead and vaccinate. So I'm seeing a whole lot more sort of suspicion with this vaccine, and a whole lot more difficulty with public messaging and getting the confidence of the public, as opposed to the traditional vaccines of childhood. But, you know, even there we have a small subpopulation that really is very worried about vaccination. And there are small clusters of the country where parents are not comfortable doing the vaccines that we all encourage. And, you know, you occasionally hear the small measles outbreak, and, boy, that's sad, because we had measles completely in an endemic kind of control. And so when you get these small clusters of folks who are not comfortable vaccinating their kids, you hear some of these things reappear. So, yeah, I think I've touched on what some of my thoughts have been. It's been a wild ride, this, because we would have loved to have achieved that 75, 80, 85% adult vaccination rate. You know, and when it comes to COVID vaccine, I really want folks, this is not messaged well, I think. I really want folks to understand the original COVID vaccine is lock and key antibody production against original COVID, but not against the variations that have, you know, come through outbreaks that have crossed the world these 2.5 years. Those antibodies that we now take with our third shot and about to consider fourth shots are in the neighborhood, very close, but not lock and key. And so therefore what they are producing is they are producing an inability to prevent COVID completely. People can still get COVID, shed COVID, not know it, but their cases, for the most part, max out at mild disease and not moderate disease. So hospitalization rates are nicely impacted if I took my third and fourth shot, even though these antibodies don't lock and key prevent Delta and Omicron and what we're about to get, which I suppose we're going to nickname it Deltacron or whatever we're going to call it. And so I want folks to understand that until we have a new specific booster, specific for the spike proteins as they exist now, from the sad reality that large swaths of the world are only 10-20% vaccinated adult, no volition of their own. That's not how they want it to be. They just have access problems. This is what keeps new variations coming. Outbreaks are 10 times higher than they need to be in other parts of the world, and this spawns variants, many of which hurt virus, but one or two help virus. So we're going to keep dealing with this pandemic cycle until we solve two problems. One, international distribution and equity from the vaccine producers. And, you know, I've got thoughts about how that should happen, but it just doesn't seem to be coming into play. And then the second would be, you know, talking to this 1 out of 5 folks out in the world who are still deliberating, some in a very political way, others not. We need to not give up. We need take our communication skills and sharpen them. And after all, that is your patient for the last 5, 10, 18, 22 years. You gotta work with them and get them to see it in a way that your point of view as the doc gets into their equation.
So, Frank, I think we are going to have to end it there, but I want to thank you very much for sharing your insights and your experience with us today on Well Said.
I'm very glad to have been on. I enjoyed it, Ira.
So my guest has been Dr. Frank Cacace. He's the Associate Chief for Education in the Division of General Internal Medicine at Northwell Health and an Associate Professor of Medicine at the Zucker School of Medicine. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. You can also subscribe to our free podcast wherever you get your podcasts. Until next time, I'm Dr. Ira Nash, and that's Well Said.